is everybody paying attention? Because this is your patient that sort of the end of the day you're a little bit tired. Although tiredness is kind of a state of mind a little bit. It's just, she's a new patient, and she's expecting you to perform miracles because she tells you that she's in her 50s, and when she was pregnant with her twins, her fraternal twins, when she's 22 years ago, she got Bell's palsy, correct? Yeah. So she got Bell's palsy. She's got a 19-year-old daughter as well now. But her Bell's palsy, so smile for us a little bit. So sit forward a little bit. So just try to do some little animations a little bit and raise your brows a little bit. So what side does she have the Bell's palsy on? Her right side. So how many patients do we see with Bell's palsy that the Bell's palsy is permanent? What percentage of the population that have Bell's palsy have permanent Bell's palsy? Thank you. It's 15%. So that's my mathematical brain. So you can look it up. You can right now. You want to even Google it, or in your iPad or your iPhone. It's 15%. So 15% of the population in North America that have had Bell's palsy do not get rid of it. So she's been having Bell's palsy issues for 22 years. Right. So when she's had her last Botox was 6 years ago, right?
No, Botox.
Botox.
Like maybe 2 months ago.
Oh, 2 months ago. What was 6 years ago? 5 years ago.
6 ago, fillers.
Fillers, yeah.
Fillers on my cheeks.
Yeah, fillers on her cheeks. She's had some fillers on her cheeks. And she's had Botox the last 2 months ago type of thing. Okay. And then if you watch her animate here a little bit, Arthur, if you can maybe watch here a little bit what I'm doing here a little bit. So just raise your brows again a little bit. Okay. And then smile. You can do a little better than that. Nice smile. Okay, good. And then now, what's the main nerve that is involved with Bell's palsy? Seventh nerve or the fifth nerve? You're right. It's the seventh nerve.
Motor or sensory?
Yeah, motor or sensory. Now you're getting just a minute now. We're coming on here because she has masseters. So her masseters are enough. If you watch her, Arthur, watch her clench her teeth here a little bit. So she's a grinder, but she grinds just one side, right?
Right.
She grinds one side. So she's grinding this side. She's grinding her teeth down here a little bit. But why does she have little masseters on this side if this side's paralyzed? What is there a branch of the fifth nerve that has some motor sensation to it? Of the mandibular nerve? Arthur? Yes, there is a little bit. So that explains why she has some masseters on the side. And she probably has, open and close your mouth, and see this joint capsule is all thickened up on this side. So this is the side that actually hurts, right?
Right.
So this is the side that hurts. You don't have to be a genius to figure this out. You just have to kind of look with, we've had 5 minutes together. We've had this bonding we've been doing here. So
he's going to start to choose your clothing now.
So she has some asymmetries that we have to deal with here a little bit and try to help her a little bit. So, and then also to compound that, she has, breathe through your nose hard, suck through your nose. So she has collapsed nasal valves. So what percentage of the population have collapsed nasal valves? Up to 15%. So she has this issue. So you snore at night, I would suggest.
Yeah.
She snores at night, so you don't have to be a genius to interpret that. She thinks she knows all these things because you've been following her around in the dark or something.
Also with exercise.
Yeah, with exercise, really difficult with exercise, really right? Because she's also, breathe through hard. Right? She's got collapsed internal valve too, Arthur. So breathe through your nose hard. Okay, and she's breathing through more, which side? The Bell's palsy side or the other side? Both sides, but this side is her normal side, and she's compensating. She's not necessarily got dyskinesias and synkinesias like some of our Bell's patients do, but she is ticking away here a little bit. You got some little ticks. You may not have noticed in your face that she's ticking away here a little bit, just some of these little synkinesis things. When did you have fillers in your orbits here?
Never.
Oh, really? Because she's got,
long
was it done in the dark or something? Because she's got,
No.
because
6 years ago, maybe?
6 years, well, it could still stay
less?
there. Because she's got fillers in this bluish discoloration is HA filler. And it's subtle, but that's a little bit distracting. So at some point we need to dissolve that and get the eraser out and kind of start over a little bit there. So that's kind of what we'd suggest. So there's a few things we could look at just to balance her out. And as you heard, Arthur and I sort of banter back and forth yesterday a little bit. A lot of our Bell's palsy patients that I inherit through different sources, I have a whole colony of them. And we do mostly now fillers rather than just neuromodulator. We used to think of fillers as form, and over on this side of the street was neuromodulators for function. Now it's both. You want to have form and function because you can get better function from doing HA fillers, right, Arthur?
Absolutely.
With Bell's palsy patients. So with our today, since we've got a half hour here or so.
Here, like
What about that?
one eye is.
Yeah, one eye is a little bit wonky there for your brow there.
Yeah, so how this goes down.
Yeah.
Is there any way to raise that up?
We'll talk about that a little bit. So what things would you like to see better besides that?
I don't like how this goes up and then down.
Okay, she's kind of pointing to here.
And
That's
down.
okay. So you've got some filler in here that's giving us a little bit of challenge with your anatomy there.
Or
Now,
maybe I'm just.
and try smiling again for us now, and see in her Bell's side and close your eyes. Okay, now fortunately she can close her eyes really well. In hemifacial spasm patients and in Bell's patients, they have the constrictor part of the orbicularis muscle works overtime and constricts the eye down, so it makes her right eye look smaller. And that's what's creating some of the issue there. So that can be corrected with Botox or equivalent
Mirror down.
in the constrictor part. Pardon me?
Put the mirror down. There you go. That's okay. Thank you.
Okay. So we're talking about the constrictor part of her orbicularis. Okay, open your eyes here. And then try closing them a little bit. And then smile. Relax it here. So yeah, she's getting a lot of asymmetry from this muscle is still, even though there's her Bell's side, is the constrictor part of the orbicularis is overactive. So you can help balance that out a little bit. So what other things would you like to see better?
That's it. Oh,
That's
maybe
it?
Here. I just
Yeah.
feel this is really deep.
Mm-hmm. So with her nasal valve issue there, she's and Arthur and I have been studying this and working with this for a few years now. And there's kind of a number of steps we do to try to improve this nasal valve and this whole region of the nose that recesses. So it retrudes because the piriform fossa is sunk at the base here. And that contributes to her breathing as well. Could you have me 2 Q-tips? Thanks. So if you watch her, for instance, if she breathes hard through your nose here, hard. Okay, and then just open your eyes here, Cheryl. And then, okay, now try breathing through your nose.
Like,
Breathe. How's that?
awesome.
Breathe through your nose. So you would like that, right?
I'd love
I
it.
think we can make that happen. All right. So she's got good structure here, Arthur, and her nasal spine is fairly deep here, so we'll be able to lift that a little bit. We'll check her nasolabial angle, because what do you think her nasolabial angle is at here? We'll turn your head to the left here a little bit so everybody can see your left, your other left. Okay, so like that here, dear, like that. So what do you think her nasolabial angle is at? It's actually not bad. We'll measure it. Turn this way a little bit. Just like that, so you're straight on, then I can turn it a little bit here. So I would say it's going to be about 85. Yeah, it's more like 80. Yeah, it's 80 degrees. So we need to lift that up to about 95 to 100. That'll help the breathing. And we'll inject her. Can we have you do her internal valves too, Arthur? Do her internal valves. Lift up the base of the piriform fossa and lift up the nasal lobules as well. And then we can get her breathing back. So I think that's one of the things we could do for her. And then I would also treat her masseters because she's pulling so much on this side that it's now creating issues with her teeth. So you're doing that through the day, it looks like. Do you do it at night too?
Probably, yeah.
Okay, so you're snoring and grinding.
Yeah, really fun to do.
Oh, you'll be all right. I think you'd be a fun girl. I may not want to sleep with you, but... Yeah, it's late in the day, Arthur. So
It certainly is.
yeah. Okay, I'm bad.
Right.
I don't have it.
I don't. She doesn't.
I did a sleep study.
Yeah. She doesn't really look so much like Pickwickian that you would imagine that she would have sleep apnea, but sometimes you can be fooled. I agree with you 100%.
Nope.
So,
Doesn't bother me.
doesn't bother you.
No,
Good.
she's fine.
Okay, so what we're going to do is we're going to concentrate. We only have 25 minutes left, whatever the story is. We're going to concentrate on some of the major issues. We can do some other stuff, even continuing tomorrow if you want. We can do some of the upper face, but let's concentrate on the lower face here just to show you a couple of things. We want to do the nasal valve thing so you can see how that works and how it's going to maintain her breathing and how she'll breathe much better. Those injections are a little more sensitive, as you saw with Lainey. They bring a tear to your eye because it's, that's the reflex that's supposed to be. So I'll leave that for the end. And we'll do some other stuff over here. So when you have her smile, you can see that she's hyperactive on the non-bell side. That's why her bell side is smoother, relax, than the non-bells, right? Mm-hmm. Because she doesn't have that hyperactive pull. Let's try this. Let's see how this is going to work. I'm going to use a product and try to give her structure around her smile to do a smile-plasty, to change her smile. How are we going to do that? I don't know either, but let's try something, okay? We're going to try something over here. We're going to use a product that has a little bit of resistance to it. So I'm thinking something that's a little bit stiffer. You know what? Give me we're going to use Refine. Give me Refine on a 27 gauge cannula. Okay? Because I've been using some Allergan products, I'm going to use some Galderma products to show you. Straight up. No blend. We're going for the gusto. We're going to clean the skin around over here. You're good?
I'm great.
I'm going to take a 27 gauge needle. I'm going to put it on a 27 gauge cannula for me. Mm-hmm. And my 27 gauge, that's my 27 gauge cannula. Perfect. You can use a 25 here too if you want. We're going to go nice and slow.
You want a 25 gauge cannula too?
Yeah, we can do that too. I don't know if
I got 25s.
Okay, well, that's a 27. We'll start with this and we'll see if we can work around a little bit. Kent, I'll give you my little syringe to hold over here for a second. Okay, so what I'm going to do is I'm going to try to structure the face over here. So we're going to do a little stick. You're good? Mm-hmm. A spin.
I primed it.
Thank you. And what we're going to do is we're out already. It's okay now. I just got to find where that little hole is again. There it is. We're going to go in, pop it, and now watch what I'm going to do. I'm flattening out the angle of my injection, and you're going to see that the cannula is, see the way it's fighting a little bit? Those are the little septi. I'm subdermal on her. Little pop, little pop. Look how superficial my cannula is. Can you see that? I'm not intradermal. I'm subdermal. How are you doing?
Great.
I'm not hurting you.
No, she's pretty disciplined.
Okay, and then I'm injecting and I'm going back. Look, little pops. I'm going back and forth.
You'd have twins. You'd be disciplined too.
For sure. Little back and forth action here. Okay, you're all right? Mm-hmm. Good.
Excellent. Excellent.
You're doing great.
You can see that actually easier on the video than we can.
Yep.
That's great.
I'm glad they can see it. I can't see a thing what I'm doing. I'm only kidding.
Yeah.
That's okay. You're doing great. Okay? What am I doing here? Am I trying to volumize her?
For you.
No. What I'm doing is I'm giving her structure. You see that little break in the lip over there? That's called the female upper lateral lip triangle. We also call it the Knowles triangle.
Knowles triangle. Yeah, the reason we do is there's a dermatologist in Toronto we teach with. His name Noel Solish, and somebody introduced him as Dr. Knowles. So it's become the Knowles triangle.
That's it. And then I'm going to go down. When you go down to the lower part of the lip, there's always a little septum that's right at the corner of the commissure over here.
I actually see it there.
You can see it. I'm going to pop through it. Watch the pop. There it goes. And I'm going to put in a little product over here too.
They're just like little speed bumps, essentially.
Okay? I'm coding back and forth. You're doing great. Okay? How quiet everybody is. I think they left. Okay. You know, if I wanted to actually augment her lip,
You could go from there.
I can go right from there. I'm in the lip. Okay? So it's a great access point. This is where the facial artery is. It's about 1.5 centimeters outside. But because I'm starting where the facial artery is and not lateral to it, means I can't hit it if I'm going this way.
The disadvantage of the videos is it always looks like you're more aggressive than we are. So that's why in doing videos, I often slow mine down about 20% because then it looks more real life because the video makes everything look accentuated.
Perfect.
So he's actually being very, very gentle here, but assertive. It's different between assertive and aggressive. He's being assertive.
There we go. Okay? I'm structuring this part of the lip. Okay, that's all I'm doing, going back and forth and structuring. And she has quite a pull over here. I'm doing anti and retrograde. You've got it right. Okay, almost finished. And now I'm putting in such a little amount of product. What am I really doing?
Breaking the septum.
That's right. I'm sepsizing. I'm breaking the septi. She's got it right. Now that I have product in there, I can do this little bit, and you can see.
So it's like almost the septi between a grapefruit section or a honeycomb kind of pattern here. And to patients, it sounds like bubble wrap a little bit.
Can I have the
Sounds
arnica,
a
please?
little odd.
Bad, though.
Yeah, it's actually
I really
pretty.
like that pimple I have right there.
You like the what?
The pimple I have on my face.
There's one up here.
I didn't catch what you were
That
saying.
one?
Yeah.
Do you have one of the? Do you have a magnifying mirror at home?
No.
Good, because we have magnifying mirror policemen that pick those up.
Yeah.
Because they're an insult to your intelligence if you have those things, to your self-esteem.
This is our bonding moment.
Can't wait.
Can't wait.
We have a
Yeah.
warehouse full of those in my city. Magnifying mirror policemen pick those up.
I used the full syringe on her. Why did I do that? Because I got distracted by you guys. I put in way too much. I'm only kidding. Because she had a major pull over there. I'm doing this as much for the look as I am for function.
Right.
Okay.
So he's doing form and function both, you guys.
Give me a little smile. A lot better.
better?
Yes.
Oh, yeah.
Oh, yeah.
Yeah.
Here.
Look at your.
Yeah, she's a pretty visual girl, so she'll be able to tell.
Okay. What will happen is it's going to stimulate your collagen. That's a
A
much
little bit
better
better.
pull.
Yeah.
Okay. Give me a
Yeah.
smile again. What happened to all those lines that she had on her cheek, guys? I didn't inject out here. I injected here medial. That's no. There's the rhizorius. No, it's
No,
it's,
lidocaine.
Yeah, the
little bit of
rhizorius
numbing
is a
in those
deeper
fillers,
muscle.
sure, but not
The only
enough to
muscle that's really. Can you give me a pucker? There you go. So her orbicularis is still working pretty good too, even with the lidocaine that's over there. She's still bunching up a bit on this side over here. Relax. Yeah, sure. You can treat her DAO. What you want to do is give me try to stick out your lower lip. There you go. Take a look at the strength of that. Okay? Look at the strength of that. Okay? Look how calm it is on the side, okay, that's had the bells. All right? But that's the idea of balancing them out just a little bit. Okay? I would still put a little bit of filler on the other side. If I use the full syringe, she can probably use a little bit on this side just to balance out the volume aspect of it. Mm-hmm. Okay? But this is going to stimulate collagen too because I was scraping the bottom of the dermis. And what I'm going to do is I'm giving her more structure. Over the long term, she'll look better at 3 months than she does now.
Yeah, for sure.
We'll get her to send us pictures.
Yeah.
But what we're doing is we're doing a smile plasty, a little smile. Atta girl. Isn't that a difference? Okay? Now what you have to do is you have to balance out, not the DAO, but more the DLI. Okay? Give me a little smile again. She's pulling. See, it's much better. But she's pulling a little bit down over here. So if we inject 1 or 2 units, when you have a Bell's patient, by the way, their muscles are hypersensitive to toxin. So use micro doses, okay?
Exactly.
I would use 1 unit only, and it'll balance out her smile over here. We should do that, but we can't get it to act quick enough that we would see it within the next day or 2. Nose?
But the tendency is when you see the Bell's patient, your nurse says,
Okay.
Cheryl is in room 1 and she has Bell's palsy. Your brain says neuromodulator.
Smile.
But if you kind of
Beautiful.
just think a little bit different and say, okay, well, let's try to create function and form, then you'll find your HA fillers like this will make a much bigger difference on her than you would ever make with neuromodulators. So that's the direction you should go. And we all have Bell's palsy patients. If you don't, then you're an unusual practice, because if you got an aesthetic practice, you'll end up having these filter into your clinic. So you just have to think a little bit more in form and structure. So we've talked about earlier today 1-dimensional, 2-dimensional, 3-dimensional, 4th-dimensional, with trying to create balance, harmony, and 5 proportions. And this is more the 5th-dimensional, trying to create form and function better. So that's where we're at now with a lot of our approaches to faces.
This is Resty Silk. I'm putting stuff intradermal to try to correct that little crease that she had, which is now practically gone. I'll do the same thing over here. And what I'm doing now is I'm also trying to bolster the dermis. You can do this with Volbella too. Okay? I don't know what I have in my hand, to be honest with you. I just picked up a syringe.
It's blended.
It's blended. Could be straight.
He knows that, but it's just...
I'm only playing around.
Yeah.
Yes, I picked up the blended
the
product.
blended.
That's going to give her a little more resistance actually in the dermis. Okay? Give me a little smile again. Bingo. I'm sorry? A little loud, sweetheart, so I can hear you. I'm sorry.
When you're trying to treat a cordial line,
Yes.
so would you do that more medial, or would you do it?
If I was treating accordion lines over here, okay, if she had really some major lines over here, I have to take a look and see if those lines are ingrained into the skin, or are they a result of hyperdynamism of the muscle, if the muscle is overwhelming. And what I will do is I will crosshatch. Ken showed us that in his talk, didn't you, Kent? You showed us.
Yeah.
You showed us how we crosshatch in this area.
Right. And do antegrade, retrograde, both directions there.
But I wanted to show you the type of effect that you can have on the cheek. Give me a smile. The type of effect, that's a girl, that you can have on the cheek without actually having to treat this area over here, because the muscle is pulling this tissue. If this tissue is more resistant, the muscle can't dominate it. It will give up the ghost. That muscle is going to start to settle down, and she's going to start to smile more naturally with filler. Okay. What are we doing next? What would you like? Nose. Let's do her nose.
Okay.
Let's do her nasal valves. Okay.
Do you want me to hold that?
I got it. It's okay. You're doing great. Breathe in. Boy, when you take a breath, you really suck it in. Leave some oxygen for everybody else in here. Just pick your chin up just a bit so you can do that again. Give me a little breath in. Okay. So where are we seeing the collapse most?
Probably going to use Voluma straight up.
On this side. Okay. So let's work on that side first. What do you say? She's got more collapse on the left?
Yes.
Okay. So Kent and I just published this thing in a textbook that's going to be on fillers.
Now, do you want to start with her nasolabial valve?
I'll start wherever you like,
I would
my
start
friend.
with
You are the
nasolabial
brains.
valve.
I will be
so
the hands.
Start with her nasolabial valve, and you're going to use BD2. And what are you going to use? 0.2.
Pick up the
I would
product
use
that you like.
Voluma 0.2 to 0.25, so 0.25 in your BD2. And I'll have you these little retractors we use for lifting up the. You can zoom in here a little bit.
Oh, okay.
Yeah?
And we
When
can
you have
show
a
you
natural-
this
you have a
little
natural
clear
smile.
retractor
It's perfectly
you can
smile.
use to lift up the ala of the nose.
A little smile is
Because when you inject the base of the nasal sill The nasal sill is here. And when you inject the base of that nasal sill here in a few moments, then you want to aim that, go straight in, and then aim it towards the lateral canthus and lift this up as you inject so you have a space. You have a space to fill it. And then we can talk about her ala and her internal valve. But you can use, there's several different types of retractors you can use to try to lift that nose up a little bit and create a space for you to work with. So these little clear ones, like you can zoom in a little bit and I can show you, like that, like this kind of thing. And we can talk about where you get these, or these little spatulas that are used in some makeup companies are nice because they're disposable. You don't have to autoclave them, clean them.
Why don't we switch sides? So
We'll switch sides and we'll go over here. So he's going to, let me just have my protractor here. So you're going to do her, lift up her nasolabial angle. We measured it at 80 degrees. So we're going to lift up her nasal. Now watch carefully, because if you're going to blink, you'll miss this.
Oh, right. I know this.
What do you know?
This technique.
This technique? Really? Okay.
Okay, now watch what he's going to do. So you actually let the nose fall onto the needle. And even though she jumped a little bit, most patients hardly flinch with this.
What am I feeling for here, guys?
Spine.
Nasal spine. If you stay on the nasal spine and you inject, and we're injecting slowly, the columellar artery is in the membranous part of the septum.
Now, with beginners, I would suggest you hold her nose up a little bit so you have a space.
I'm just trying to get
There,
her.
just a little bit like that. So you have a space to fill, otherwise there's not a space. So if you lift that up as you fill, then the filling creates that lift. So he's going to go just a little bit more, please.
Whatever you like, my friend.
Okay, a little bit more.
Guys, you can see it. I didn't take a look at the monitor.
More.
Slow injection on bone.
Okay, a little bit more.
Yep.
Voila.
You happy with that?
I'm happy with that. Now let's just measure this here.
Here we go. Oh, it's a little hard to see. I'm going to lift your head up just a bit so they can get a good angle. Whoa.
So we went from 80 to 110. It's sort of like your Porsche, you're going from 80 to 110 in 6 seconds.
Look at the smile, guys, when
So-
she's talking now.
You see that?
Watch when the lidocaine wears off, because we'll take a look at her in an hour. Let's track her down tonight, wherever she is, okay?
So we went from 80 to 110 degrees. So that by itself, try breathing in a little bit better. So even that will create some better flow through these collapsed external valves, right?
Yeah.
Not trying to talk you into it, but just
I'm so
even that step. There's about 5 steps here to get a good end result. Now I would suggest the next step is to actually lift the nasal sill up and out. So I'll give you this.
He's going to retract it for me.
So I'll.
You can go ahead, or
Yeah, I'll
because I want to
retract
keep my
it.
hand out of the way, so we'll see.
So you're going to need a little bit more than that.
Yeah, she's getting me.
You're going to get that. So you
she's
need
loading
about
up some more.
0.2. Can you use 0.2, please?
Yes, sir.
Okay, thank you very much.
She's loading up. I already told her.
Okay.
Loads.
So BD2, 0.2. I don't usually measure amounts for anything, but this is one of the places I think it's a good idea. And even if you've done lots of these noses, sometimes I'll do 5 or 6 of these noses in my clinic a day, just in people who walk in with something else, because collapsed nasal valves are really common.
Happy with that?
That's perfect. Thank you very much.
You're very welcome.
So he's going to go.
Turn slowly
This is
for
the
me.
part that's it's hard to do on video. It's hard to teach because there's a little third dimension to it. So he's going to go right at the base of the nasal sill.
Where I'm aiming for. You
There
guys
we
can
go.
come in a little
See?
bit closer, or
Yeah,
can
come
you?
in so you can see that.
Let's look really right up
Be
her
fine,
nose
Doc.
and see what's doing in there. You're
Okay.
clean. Don't
so
worry
lift
about it.
So we lift this up a bit so we have a little space.
I'm looking for the pet frog that I lost when I was a kid.
Okay. Okay.
It's not there. Okay. So
Okay.
what we're going at the base of the ala. Little
Base of the
flip.
nasal still almost here. Okay, and then as you inject, lift this up a little bit, and then you have a space. Go just a little deeper. There, thank you. And then lift this up a little bit and really slow. I'm like Arthur, I'm a fast, slow injector. In other words, it's like driving your car down the road. You look ahead and you know exactly where you're going to go next, but you actually inject. And see, he's aiming right for this lateral canthus, essentially is where he's going.
Can you see that? My hands are in the way.
So that's kind of where he's going. And that's what's hard to video and explain. Now, if you watch when we're done here, because he's almost done, this little trick will make your trip worthwhile because it's a common problem. Okay, very good. Thank you. Okay, now breathe through that side of your nose. Still going to collapse, but it's still breathing better, right? Breathe.
So much better.
Oh, I mean, let's hear it.
So much better.
Well, yeah.
Here's $5.
Love it.
I'm not trying to make
Here's $5.
words in your mouth, but usually patients' eyes will go. They would just go, wow. I mean, it's just an immediate response.
Oh, it's great.
Breathe in.
Yeah, she's still got a collapsed valve, but
No,
it's not as
so
much
much
because
better.
she's
the
still
other
got
little
some
bit?
other issues. So could you do her alar lobule a little bit here?
Sure.
Okay.
Give me that little teeny bit that I had left over.
So we're gonna give her a little support to the alar lobule here now. Here, I'm gonna fall off a cliff if I go that way.
Yeah, don't do that. You're good?
Mm-hmm. Great.
Great. Okay.
Okay.
If you watch when she breathes in now, breathe in. You're breathing better.
I love this. I really do. I'm not kidding you.
Okay. Breathe in as hard as you can now. There.
There's the problem right
She's
there.
still collapsing over here, okay?
That's the internal valve.
Okay, so what we talk about the nasal valve or the internal nasal valve is the junction between the lower lateral cartilage and the upper lateral cartilage. It's called the scroll portion of the nose because the lower lateral cartilage comes along and bends back and it holds hands with the upper lateral cartilage. Very commonly in rhinoplasties, when we remove the cartilage, which is what we call the cephalic or the upper part of the lower lateral cartilage, okay, we destroy the scroll area. If a patient hasn't got a problem with a nasal valve issue over there, they can develop a problem because we've disrupted the valve. Injections in this area right over here.
What kind of product do you want there?
Oh, I want something a little lighter than Voluma.
Yeah, so you got to use something that's a little personality, an internal valve personality
I
product.
used a little bit of silk on her before, didn't I?
Yeah. So use the.
Yeah, is that one? Okay. So we'll load up a little bit of silk. That's no
You got a little blended silk there.
Yeah, we'll put some blended silk in.
Yeah, so a little blended silk is perfect for this because you want a little forgiveness.
Can I have a
We'll
cleanser,
just lift. We don't need to lift this out too much. It's easier to actually inject it, not lifting it out.
Breathe in. There it is. You can see
So,
it's trying to go
Yeah,
ahead
just
and-
zoom in about like that. That's good.
So two things. I'm off midline here. Where am I injecting? In dermis, correct. The other thing is to look at is that she has large pores here, so it's going to be a little bit of a struggle because what's going to happen is the product's going to try to come out from the pores. So I'll avoid a little pore over here, small little stick. Good girl. And I'm going to start to inject very slowly. There it comes out of a little pore. Look, it's coming out of the pore beneath it. So this will be a little bit of a challenge. There we go. We found a place that's not connected to that pore. Look at the blanching of the skin. If you get blanching, you're in the right plane. Okay? A little bit of blanching over here. You must be intradermal, not only for vascular. There it comes out of a pore again. Not only for vascular, okay? But you have to be, I'm sorry, sweetheart, I know it's a little tough because of those pores. I'm really going superficial. Okay. You have to be intradermal because if you go subdermal over here, forget about the little arteries and stuff. I'm not talking about vascular issues. There we go. Okay. Hold this, please. What you're doing is when you breathe in, because the skin is being sucked down, it does this. It collapses. If you're in the dermis, what you've done is you've created a suspension bridge. What you've done is you've thickened the dermis so that it's like cardboard and it can't bend in.
Okay, relax.
If you go under the dermis over there, you're putting pressure between the dermis and the cartilage. You're forcing the nasal valve in and you'll make them worse. So make sure that you're intradermal. Seeing product come out of the pores like that, is one of the side effects in somebody who has enlarged pores.
Could-
But we're going to take a look over here.
Right there?
Sure. You marked a little more for me?
Yep.
That's really up where the valve is
Yes.
right here.
Right there.
Let me have a little
That's
bit
where
more.
I marked that is where the valve is. Okay?
Okay.
So watch her breathe in. Suck in hard. Yeah, so you want to lift that valve up.
Feels like it's worse now.
Yeah, that's because it's numb.
That's the anesthetic there. Just hang on, it'll be fine.
I'll
Hang
get
on.
that in a second. It's all numbed out now.
That's the numbing sensation
Yeah,
that's
it's okay.
distracting. It'll be fine.
Are you picking my nose now?
I'm not picking, I'm just pulling, making sure that I massage it so that we don't have any areas of...
You can pick it if you want.
You can pick your friends, and you can pick your nose, but you can't pick your friend's nose. Hold this. Here we go. Okay, turn your head a bit to the side, and we're going to help it just a bit over here. There we go. Intradermal injection. I'll keep my hands out of the way. So
Now we're talking here.
Okay. Intradermal injection again. And I'll go back into an area that now is a little bit blanched, which shows me that the anesthetic has gotten in there as well. Okay. We'll even take it down a little bit lower over here. Okay. And we're going to massage that in. Go ahead, Ken. So use a very thin product because you don't want to add width. What you're doing is you're adding structure to the nose. Actually, in this product over here, yes, but minute. She put in maybe there's 1 in a millionth of epi. And you can see that she doesn't have really much blanching over here. And there we have the first nasal massage on video.
That feels really good.
Feels
Feels
what?
good?
Feels good.
Yeah.
Breathe in. Try to collapse it. You're having trouble. Breathe in normally now.
Much better.
Much better?
Yeah.
Okay. The other thing you should look for, and this is one of our final steps, is the fact that they can have collapse over here as well.
Yeah, she got her piriform fossa is sunk in here.
Yeah, it's breaking here a little bit. Ready for the last injection?
Yeah.
Okay, we'll make it do this, so this will last you a little bit of time. So here's our injection again over here. I have very little bit of product on my needle. There we go.
Yeah, now we're talking. This is what I would do is just establish some strut work support of the lobule, the alar lobule, which is actually the valve. It's the valve flap.
Breathe in.
So the valve flap now should be better. Now breathe in. That's better?
Yeah.
Now we're talking. Okay. So that's one of the 5 steps in kind of doing this. We haven't done our piriform fossa yet. So
Let's do it.
on bone. So we're using what product were we using here? The Resti
Voluma,
family.
Yeah, sure. Yeah, Voluma here. We can
So
try the
Voluma would be great and straight up.
Is that a fresh needle?
Yes, that's
Great.
Yeah, straight up.
Okay, guys.
I also use a cannula, 25 gauge cannula, and we come right up to the base of the nose in the no-fly zone. And as you're at the base here, we lift the nose up and have a space to fill that with my cannula, and that works really well for this as well. The only problem with this zone is sometimes you have a little numb lip for a couple hours. You notice that, Arthur? With
Yes. Yeah, there's that little nerve that comes down.
Yeah,
over.
so that's just have to tell patients of that. Okay.
Guys, where can I inject here? On bone or in dermis. Nothing in between, right? Nothing in between. So I did this with a couple of you guys at the break over there before. I'm going to show you. Do I angle up? Down towards? Opposite commissure. Very close to the alar border. I'm going to lean across here so they can see. I retract the nose away. I have my needle here. Okay, I'm in. I must touch bone. I cannot go any deeper. Do you see that? Okay, so I'm on bone. I'm on the piriform right now. If you want to go ahead and aspirate, you can aspirate. Okay, we have about 0.3. I'm going to put in about 0.2. I'm lifting the
See,
nose
he's lifting up the nose a little bit to create a space. So there's a space there, and you want the filling creates the lift. So you want to lift that base of the piriform fossa that's retruded. And this will also enhance her breathing ability as well.
Where am I looking? Beautiful. God, you guys are good. Paid attention, actually. I thought they were just here to socialize. Okay, we're almost done. I'll finish off what I have in the syringe over here. Okay? Beautiful. I'm prepared in case I skewered the artery. I guess I didn't.
Now try breathing a little bit.
Tomorrow I'm probably going to hit.
Good.
See, now what she said, you missed that. What did you
Oh,
say?
that's good.
Yeah.
Say it again, but louder.
Oh, that's great.
It's the O part that you have to work on. Give me that. Oh, that's better. There you go.
Okay, in lieu of time,
Late
we're
in the
going
afternoon.
to do her right nasal sill and lift up this. So same product there. With a mini, we're going to do about
Small
a point,
amounts.
point
Really
two
small amounts.
of
I don't
the
think
level
we've
here,
even hit
mini.
0.3. Most of it has been put in 0.2 over here into the piriform region, and maybe 0.1 total all the way around. So, the idea is with the nose, especially, as we say before, it's where a little difference in anatomy not only makes a huge difference in appearance, but a huge difference in function. Okay? And so you're using small amounts. Are you charging per syringe and per amount over here? If I'm going to use a total of 0.3 or 0.4 cc's of a syringe to do her entire nose, am I going to charge her a third of a syringe? No, she says. What am I charging for? The result. If you were to charge a patient $700 or $800 to do this type of thing, to redefine her nose and to improve her breathing, would she be happy? She'd think it was the best deal in the world. And you've used a total of maybe $50 worth of product. Are you ripping her off? The answer is no, because what is she paying for, guys? She's paying for the hand, not what's in the syringe. Nasal sill. Time, talent, and expertise. I like that. That's what it is. Look, you guys are spending a day here with us on a Saturday and a Friday night. There's a value to that. Your competitors aren't. All right, we start from the beginning. You're doing really great. We're going to go ahead and inject the bottomless part of the sill over here. So I'll have to retract you from my side. I want to make sure that people can see. They can. What I'm going to do actually is I'm going to lift up. Can you see? Yeah? And I'm going to let it fall back down into it, okay? And now I'm going to lift up and create that space.
Space underneath a little bit. Just
that Ken talked about. Small injection going all the way in. Slow injection.
you have about not quite 0.2. So I would use all of that.
Yeah, I'm going to use it all. Okay, so.
You can talk and chew bubble gum at the same time. So
Facial artery is coming up over here. Okay, let me just do this. I don't want to speed it up.
No.
The facial artery, very often, there's philtral branches that are coming off the superior labial. There's a columellar branch that can come off of the facial artery itself. I have a whole bunch of slides to show you this if you want to see. I'm going to back out a little bit now and give her really an injection into where we would make, for those of my plastic surgery friends over here, this is where you would do what we call a Weir excision or a wedge excision to narrow a nostril. Okay? Slow injection. Really, patients haven't been bleeding much at all.
Good. Great.
Good, great. Okay. Columellar artery can come off over here and run along the alar base over here. I'm going above it and deeper to it. The lateral nasal artery comes across over here. Sometimes it ends as the final portion of the facial artery that doesn't even connect to the angular sometimes. I think you might have seen that on my little talk before about accidents in the nose. So that comes across over here. It gives off an alar branch which is running in the alar crease. So by staying down over here, my risk is to the angular and my risk is to the facial, maybe the columellar. But they are all lateral to where I am, and I'm heading north into the area where we go ahead and we actually, like I said, cut out the wedge that you do in order to narrow nostrils, okay? Where you do that Weir excision right along the side over here. So there's only small little vessels over there, and if you inject slowly, you should be fine.
Let's do her.
Remember, no 100% guarantee, but if you do things slowly, and if you
here.
have an understanding of what's going on over here, you watch here, you should be okay, guys. More than should be. Piriform fossa. Yeah, that's okay. We'll use it because we used a little bit. Okay. So how am I going to inject the piriform fossa? We're going to do the same thing on this side. Going to clean, always. Every gauze that I have has a little bit of chlorhexidine on it. Sometimes when you put your hole in for the cannula, they start to bleed from the hole as your cannula is in there. And I see people take an unsterile gauze and touch the tip of the cannula that's going into the patient. Bad technique. It's like trying to play around with the liposuction cannula before it goes in. Bad technique. Don't touch the part that goes into the patient. But if it has a disinfectant on it, then you can put a little bit of pressure on it and stop the bleeding. Here's my angle. You can see I'm almost standing behind the patient. Here's my angle. I retract the nose. I tilt her a little more towards me so I can get a good angle approach over here. I'm aiming for my finger over here. There we go. And now I got to make sure that I'm down on bone. I don't feel bone. I'm not injecting. I just felt the bone over here on her now. He's going to lift the nose so I don't block you. And I'm going to start to slowly inject. Okay.
Now, if you happen to be ambidextrous, you can inject these from just one side and use your offhand to inject this side as well.
Correct.
I often inject with both hands, not at the same time, but I'm fairly about 90% ambidextrous, so I could inject both sides equally the same.
What I'm going to do now is I'm going to cheat. I'm going to lift her nose. I'm going to come off the periosteum by 1 millimeter. And I'm going to lift my needle at the same time.
I like that.
And I'm going to inject into the bolus that I just created.
Yeah.
Nice slow injection. So I'm putting the second ball of that snowman or that ice cream cone into the first ball to go ahead and to give her a little more lift. Good. Nobody bleeds. Good for you. And a little massage. You're going to feel some numbness in your lip. It's a good thing to do this before you decide to do lips sometimes because you get the anesthetic effect. Breathe in. How do you spell relief? K-E-N-T.
It feels weird. So sometimes the patients have a hard time sort of subtracting the numbing from the actual flow of air.
Restylane silk.
But it should feel a lot better.
You're getting the idea now. You understand? We have a dance going on behind us, and we're doing pretty good. She's going to start passing me stuff. You know, most of the time when I'm injecting, I don't even ask for the product. My hand is out, and my nurse puts in the product that she thinks is the right product, which is usually the product, and not usually, it's always the damn product that is the right product. So I just put my hand out and I say, yeah, that's what she wants me to do. She wants me to do a valve injection because I can see that it's the thin product that I'm supposed to inject over here. Breathe in. You have very little over here, but I'm just going to balance it out. Okay. Let me have a cleanser again. Make sure we clean always. I'm going to retract. Let it fall in. Small injection. You're not going to like me for this, but you're going to bear with it. Good. We're going to go ahead and we're going to advance it slowly. Intradermal, guys. I want to see product coming out of the pores if it has to. Definitely not subdermal. I'm not as delicate as Kent was with that little thing up your nose and a little ball rolling over the top and all those types of things. Beautiful. You have a little depression here. I might as well fix it. Good. There we go. Last injection, the one that you don't like.
What was the question?
We did a patient, when was it that we did the patient, Kent? Was it last time in February? No, it was even, I think, the time before it.
No, it's February.
It was in February.
Yeah.
And she's still breathing better.
We're a little conservative like this today, and that's kind of good. So we'll start out, and I'll often top these patients up in maybe 2 or 3 months. And then once they get them where we want it, then they can last up to a year, sometimes even longer.
How can you make the product last longer in the nasal valve region? Sorry? I heard somebody mention it over here. Yeah. Go after the nasalis.
Mm-hmm.
You know, the way we lose product around the mouth and in areas of high movement is because of shear. So if you go ahead and decrease the shear, the product will last forever. I expect these results to last at least a year.
Yeah.
Sometimes you have to
Oh, yeah.
top them up at about 6 or 9 months. And as you're doing it, you're stimulating collagen and elastin. So the chances are that you're not going to have to do it after a while. Her own collagen is going to take over for what you've been putting in over there. Breathe in. Bingo.
Great.
Great? You're happy? Great. You're happy. We're happy. Right?
But it will feel weird for about a week. Just feel a little odd. The patient says, "Oh, I don't like that." It just goes away.
Probably.
It's when you're talking and trying to move your nose a little bit and blow your nose and kind of just the natural hygiene things of
Feel a
your
little smile.
face feels a little weird.
Good. Thank you.
Yeah, great. Okay, good. Very good.
Thank you.
Gee, that's for you.
What?
That clapping is for you because those are tough injections.
Yeah,
You were
you did
really,
well.
Cheryl, you're amazing.
Oh, yeah,
Yes,
you
you're really
did
amazing.
great.